Cutaneous mycosis restricted to keratinized layer of the skin, epidermis, hair and nails, elicit an inflammatory response, resulting in more serious skin disease with uncomfortable, painful symptoms. Symptoms include itching, scaling, or ring-like patches of the skin, brittle or broken hairs, thick, discolored nails, caused by fungi of dermatophyte group. Cutaneous mycosis are perhaps the most common fungal infection of humans and usually referred as tinea, Latin for worm or ringworm. The gross appearance of the lesion is that of an outer ring of an active, progressing infection with central healing in the ring. Dermatomycosis are caused principally by species of three closely related genera of keratin metabolizing filamentous fungi genera, namely Trichophyton, Microsporum, Epidermophyton. This infection may be characterized by another Latin noun to designate the area of body involved. Tinea capitis, scalp and hair. Tinea pedis, foot. Tinea corporis, the body. Tinea cruris, groin. Tinea barbi, beard. Tinea ungulam, nail. Subcutaneous mycosis. The subcutaneous tissue, dermis or fatty tissues, the deeper layer of the skin. Symptoms include ulcers that progress and do not heal, and the presence of draining sinus tracts. The following subcutaneous mycosis are common: sporotrichosis, chromoblastomycosis, maduromycosis, rhinosporidiosis. Humans and animals serve as accidental hosts after traumatic inoculation of the organisms into sporotrichosis, chronic infection caused by sporotrichium sichenki, dimorphic fungus. Sporotrichium sichenki exists in nature where it has been isolated from soil, wood, and plants. The infection is an occupational hazard for farmers, nursery workers, gardeners, and miners. It is commonly known as rose gardener's disease. The infection is characterized by the development of nodular lesions of the skin or subcutaneous tissues at the point of contact. Maduromycosis, Madura, foot mycetoma. The infection occurs most often in the feet but may appear on the hands or buttocks. At least 6 distinct species of filamentous fungi can cause this type of infection. One of the etiologic agents, Escherichia boydii, can invade the bloodstream in the rare instances and cause lesions of the brain, meninges, lungs, sinuses, prostate, bones, and other internal organs. Source of infection: injury such as a minor scratch, a bruise, or a wound produced by a splinter occurs more commonly in men than in women and can be related to the soil and the opportunity for trauma or injury to an exposed surface of the body. The mode of onset is neither characteristic nor uniform, with or without a history of previous injury. The first detectable lesions may be small papullae, a small nodule which is deep-seated and fixed, an indurated area surmounted by a vesicle or an abscess which ruptures with subsequent formation of a fistula. The classical picture of swellings and deformities may develop within a period of months, but it usually takes such longer. Nodules frequently develop about the openings of fistulas, from which an oily fluid containing the diagnostic granules is draining. The diagram of mycetoma of foot. Systemic mycosis. Systemic mycosis are fungal diseases that may affect internal organs and may disseminate to multiple sites of the body. Symptoms very general as fever and fatigue, chronic cough and chest pain. Systemic mycosis occur in three disease forms: acute self-limited pulmonary, asymptomatic to severe, chronic or pulmonary, or disseminated. The agents of subcutaneous and systemic mycosis are normally saprophytic fungi growing in the soil. Humans acquire this mycosis only when the spores of the soil organisms are either inhaled or introduced into the body through a break in the skin. The systemic fungi include blastomyces, dermatitis, blastomycosis, coccidioides immitis, coccidioidomycosis, histoplasma capsulatum, histoplasmosis, paracoccidioides, brasiliensis. Opportunistic mycosis. The opportunistic mycosis caused by fungi that cannot infect healthy humans but can cause serious, often fatal, mycosis in people whose resistance has been lowered. Immunocompromised patients. The highly susceptible groups for opportunistic fungal infection are AIDS patients, leukemic patients, individuals on chemotherapy for treatment of cancer. Although there is an ongoing list of opportunistic mycosis, some are seen more often and includes candidiasis, cryptococcosis, aspergillosis, zygomycosis, trichosporonesis. Predisposing factor for fungal infection: increased moisture, obesity, invasive medication procedure, wounds, tight clothing, underlying debilitating disease, diabetes, HIV infection, malnutrition, burns, prolonged administration of corticosteroid, antibiotic or chemotherapy. Laboratory diagnosis of fungal infections. Specimens used for diagnosis of fungal infection include respiratory tract secretions, sputum, bronchial washing, throat swab, cerebrospinal fluid (CSF), blood and bone marrow aspirates, tissue biopsies from visceral organs, urine and urogenital specimen, skin, nail, hair scrapings and swabs. Examination method: microscopic methods. Direct microscopic method include saline mount, potassium hydroxide preparation, staining method, calcofluor white, lactophenol, cotton blue, India link preparation, etc. Note: microscopic methods should be confirmed with culture or antigen testing when available. 2. Culture method. Culture method media for the cultivation of fungi must include source of nitrogen such as nitrates, amino acid or urea, carbon source, which is usually glucose, vitamins and minerals. Other supplements such as blood and antimicrobial may also be added. A primary isolation media. Primary isolation media should include media with and without blood and media with and without antimicrobial. 1. Sabrous dextrose agar. 2. Dermatophyte test media. 3. Mycosal agar. 4. Brain health infusion medium. 5. PHI biphasic culture bottle. B. Differential test media. These media are used to differentiate virus groups or species of fungi. 1. Commial with twin 80 agar. 2. Cotton seed agar. 3. Bird seed agar. Antifungal drugs. Since fungi are eukaryotic cell, antibacterial agents are useless in eradicating mycosis. Serious problems continue to plague the use of antifungal compounds are therapeutic agents. Absence of selective toxicity, great resemblance in cell structure and metabolism between fungi and mammalian cells, ergosterol, cholesterol or less than cholesterol, insolubility or decreased solubility of many antifungal agents or poor absorption. So the GIT demands the use of parenteral routes for tissue penetration and distribution of systemic antifungal fungi tend to infect poorly. Antifungal. The limited number of molecular targets that fungal agents can attack to kill or disrupt the metabolism of fungi makes the development of the new drugs more challenging. Antifungal agents currently available for clinical use belong to three major classes, namely pollens, azoles, 5-fluorocytosine. Additional antifungal compounds such as allylamines, candines, and nucleosides analogs are also available. Pollens. Pollens are characterized by a large macrolide ring of carbon atoms closed by the formation of an internal ester of lactone. The macrolide ring contains 12 up to 37 carbon atoms. The conjugated double bond structure is contained exclusively within the cyclic lactone. 6-14 hydroxyl groups are distributed along the macrolide ring on alternate carbon atoms. Pollens increase cell membrane permeability, which causes leakage of cellular constituents, that means amino acids, sugars, and other metabolites, leading to cell lysis and death, inhibition of aerobic and anaerobic respiration. Pollens could also cause oxidative damage to the fungal plasma lemma, which may contribute to the fungicidal activity of the drugs. Pollens have significant activity against most Candida species, Cryptococcus neoformans, dimorphic fungi such as Sporotrix, Sichenki, some Demacious fungi, Amphotericin B, IV, and Nystatin cream belong to this class. synergistic effects between amphotericin B and flucytosine against Cryptococcus neoformans, C. albicans, aspergillus, and histoplasmosis. Resistance to amphotericin B and nystatin are rare. Few mutant strains of Candida and Aspergillus species decrease the total ergosterol content of the cell without concomitant changes in sterol composition. Presence of low affinity pollen binding sterols instead of ergosterol, 3-hydroxysterol or 3-oxosterol. Reorientation or masking of existing ergosterols leading to low binding. B. Azoles, synthetic antifungals with 5-membered ring structures containing 2 nitrogen atoms, imidazoles, or 3 nitrogen atoms, triazoles, with a halogenated phenyl group attached to one of the nitrogen atoms through a short aliphatic chain. Antifungal activity of azole is mediated activity mainly. Antifungal activity of azole is mediated mainly through the inhibition of a cytochrome P450 dependent enzyme involved in the synthesis of ergosterol. Inhibit cytochrome carbon oxidative and peroxidative enzymes. Azoles influence cell membrane fatty acid, causing leakage of proteins and amino acids. It inhibits catalase systems, decreases fungal adherence, inhibits germ tube and mycelia formation in carbon albicans. Azoles possesses broad spectrum antifungal activity against Candidiasis, Cryptococcus, Coccidioidomycosis, Blastomycosis, and histoplasmosis. Partial efficacy against aspergillosis and sporotrichosis. Representative antifungals in this class are miconazole, ketoconazole, or imidazole, intraconazole, fluconazole, or triazoles. C. 5-fluorocytosine or 5-FC, 4 amino acid, 5-fluoro, 2-pyrimidine, a synthetic fluorinated fluorinated pyrimidine used as an oral antimycotic agent. The antifungal activity of 5-FC is mediated through one of 2 mechanisms: 0 disruption of DNA synthesis, 0 alteration of the amino acid pole. 5-fluorocytosine 5-FC displays significant antifungal activity against Candida and Cryptococcus genera. It also exhibits moderate activity against Aspergillus species and Demaciaceous fungi. Coccidioides, histoplasma, and dermatophytes do not respond to 5-FC treatment. Many fungi are either inherently resistant to 5-FC or they develop resistance to the drug. Novel antifungal agents. Allylamines and thiocarbamates, naftifine and terbinafine are the two major allylamines in clinical use, and tolnaftate is the only thiocarbamate available for use. Both function as non-competitive inhibitors of squalene epoxidase, an enzyme involved in the conversion of squalene to lanosterol, which is an essential health step in the synthesis of the fungal cell membrane. No, naftifine is used as a topical agent, while terbinafine is administered orally. Terbinafine inhibits the growth of dermatophytic fungi. Naftifine hydrochloride as 1% gram is effective against Tinea cruris and Tinea corporis. Octanidine and pirtenidine, structurally similar to chlorhexidine, cause extensive leakage of cytoplasmic contents from C. albicans. Morpholines, synthetic phenyl morpholine derivatives with amorolfine as the sole representative, acts on the ergosterol synthesis pathway, used only for topical treatment of superficial mycosis. Statins, small cationic histidine-rich peptides, exhibits fungicidal activity against several candida species. C. neoformans and A. fumigates. Thank you, the end.